Good evening. Thank you very much for the invitation to participate in this session. I think we can all agree that over the last few decades, early surgical decompression has really become one of the cornerstones of care uh, for spinal cord injury patients in general. But central cord syndrome patients remain a holdout. They remain one group of spinal cord injured individuals for which there is remnant controversy about the role of early surgical decompression. Those are my disclosures. So the case that Brian has presented is quite prototypical for a central cord syndrome patient, perhaps on the more severe end of the spectrum. So 73-year-old male with a significant hyperextension injury after a fall, and presents with a C4 Asia impairment scale grade C neurologic status with no fracture or dislocation on the CT scan and an MRI that shows multi-level spinal cord compression with abnormal cord signal change seen throughout. So the pertinent question for us today is, what is the evidence for early surgical decompression in a patient such as this? Even though there's no instability, the cord is quite compressed and injured, and can we help his chances for recovery by taking him to the operating room in an expedient fashion? What are the pros and cons of that? We do know that increasingly that time is spine, or rather spinal cord. This refers to the fact that after the primary injury event, there is initiated a downstream cascade of deleterious pathological processes collectively referred to as secondary injury mechanisms. And these ultimately work to expand the zone of neural tissue injury and worsen neurologic outcomes. And all potential neuroprotective treatments act to mitigate certain aspects of this cascade and hopefully help neurologic outcomes. And there's been a lot in the translational pipeline with respect to putative neuroprotective treatments over the last decade or so. Of course, these include pharmacologic agents, but also procedural-based therapies such as decompressive surgery. And there's been a number of studies that have come out over the last 10 to 20 years, looking at the relative merits of early surgical decompression. This is our Discusson study, which is now over 8 years old. This was a prospective observational study which looked at outcomes, neurologic and otherwise, between patients treated with early versus late surgery relative to a 24-hour cutoff. The patients who had early surgery experienced 2.8 times greater odds of experiencing at least 2 grades in their Asia impairment scale grade score at 6 months. Of course, there's been a number of other studies performed in this realm and have been summarized in a number of systematic reviews, including this one, which was from Middendorf in 2013. He included 18 studies, and he acknowledged there was some heterogeneity, but overall early surgery was associated with higher motor score, neurologic, overall neurologic improvements, as well as reduced length of hospital stay. The AO spine acute spinal cord injury guidelines that were put out in 2016 included surgical timing as one of the topics of interest. There was a robust evidence synthesis coupled with a modified Delphi process where the guideline development group weighed the pros and cons of early surgical decompression. And in the end, based on the low quality evidence available, we provided a weak recommendation suggesting that early surgery may be offered as an option for acute spinal cord injury patients regardless of level. But that's for spinal cord injury patients in general. What about central cord syndrome patients? I think Brian talked about this briefly. I think one of the studies that highlights the remnant controversy the most was this 2010 article where Failing surveyed 1,000 spinal surgeons internationally, and he found that while most greater than 80% advocated for surgery less than 24 hours in virtually all cases of spinal cord injury, central cord syndrome was the holdout, where only 50% of surgeons advocated for surgery in less than 24 hours. So in order to understand what the basis for this relative reticence is amongst spine surgeons to operate on central cord syndrome patients early, we have to go back a long time. In fact, almost 70 years to this original article by Schneider and colleagues. And after Schneider discussed the 10 or so patients with central cord syndrome that he diagnosed and treated, he surmised that surgical decompression of the spinal cord is contraindicated because spontaneous improvement or complete recovery may occur. Furthermore, operation has actually been known to harm these patients rather than improve them. So this work and other works which came out shortly thereafter have set a set of treatment principles and general statements around central cord syndrome. Um, and these statements and these principles have carried forth over the decades and continue to be written about and observed really in modern spine surgery and neurotrauma. But I think it's important to reevaluate each of these uh, practices and treatment principles in the modern day to understand whether they still remain true. So one of the key bits of dogma around central cord syndrome is that patients with this syndrome have very good prognosis. And so that operating on them can't really add much to the already favorable natural history. And that's true, of course, that if you look at gait or Asian motor score recovery, they do quite well. However, as Dvorak and Kwan and others have written, if you look at other metrics for outcome, such as quality of life, disability, spasticity, and neuropathic pain, these patients actually remain quite impaired and have persistent disability going forward, independent of their motor score and gait related outcomes. So there is room for improvement. The second bit of dogma is that surgery for central cord syndrome causes harm. It's important to remember that in Schneider's paper, the surgery discussed was a posterior transdural approach to resecting an anterior disc osteophyte complex with spinal cord retraction, a surgery that we would not contemplate today. It's also important to remember that we've come an extremely long way, of course, in terms of treating patients with cervical spine trauma. We can reconstitute structural integrity of the spinal column as well as decompress the spinal cord quite quickly and with low morbidity. And this has been reflected by the data that's come out in the modern era. Of all the studies that have emerged, none have documented a particularly high morbidity rate amongst those treated with early surgery from a neurologic perspective or otherwise. So surgery can likely be done quite safely. I think the other thing that's important to remember, at least from a theoretical or conceptual perspective, is that those most likely to benefit from a neuroprotective treatment, such as surgery, are those where the primary injury is less severe and such that the secondary injury is possibly more responsible for the final outcome observed. So in the real world, this patient with a severe facet dislocation and an Asian impairment scale grade A cervical spinal cord injury has a very severe primary injury. And as a result, the secondary injury is less likely to play into the final outcome. However, this patient with a central cord represented above in the top picture has a less severe primary injury, and neuroprotective treatments such as surgery are likely to help this patient the most of any spinal cord injury that we see clinically speaking. What does the evidence show? Well, there's actually not much evidence available. This is probably the best paper that's come out over the last 10 years or so. Involved 73 patients with a cervical incomplete spinal cord injury without instability, and those operated on within 24 hours had better motor, overall neurologic, and functional outcomes at 12 months, and no patient deteriorated with early surgery. So early surgery was also found to be safe. Looking at this evidence body, which is albeit quite limited, in conjunction with discussions amongst the guideline development group using a modified Delphi process, we suggested that early surgery less than 24 hours be offered as an option for central cord syndrome patients, with the overall strength of recommendation being weak. So in summary, is early surgery for central cord syndrome in the stable spine to be recommended? Well, yeah, it certainly makes a lot of sense. More evidence is definitely needed, but in the absence of mitigating factors, this is one potential option to help improve patients' recovery, and this can be done with an acceptable risk profile. Thanks for your attention.